From Literature to Bedside, Episode 9. Low anterior resection syndrome, the bowel dysfunction that follows the operation we count as a success. Today, what drives it, who is at risk, how we measure it, how we prevent it at the table, and how we treat it when it is established, with the evidence graded throughout. We restore continuity and the sphincter is preserved. Yet, a large proportion of our patients live with disordered bowel function afterward. In 2020, the first international consensus, designed with patients, defined the syndrome as disordered bowel function after rectal resection, leading to a detriment in quality of life. It is built around 8 priority symptoms and 8 priority consequences. Note what that means. Quality of life impact is not a downstream outcome. It is part of the definition. And the consensus is conceptual. It is deliberately distinct from any single symptom score. Clinically, it presents as 2 overlapping phenotypes. The fast or wet pattern, urgency, frequency, clustering, and incontinence, and the slow or obstructive pattern, incomplete evacuation, straining, and fragmentation. Most patients sit somewhere on both axes, and as we'll see, the mechanism map explains why. The scale of it. NAPR, some degree of altered bowel function, affects 60 to 90% after low anterior resection. On meta-analysis, major LARS, the severe end, pools at around 41 to 44% at a year or more. And it matters. The LARS score correlates with quality of life at roughly minus 0.65. Nearly half of our sphincter-preserving patients carry a severe, life-altering bowel disturbance. Does it settle? Partly. An individual patient meta-analysis shows scores improve over roughly the first 18 months, then plateau and remain stable to 3 years. So counsel honestly. There is meaningful early recovery, but for many, the dysfunction is permanent, not transient. And the window where reservoir reconstructions help is that same early window. Pathophysiology, and this is where the thinking has moved. LARS is no longer simply you remove the rectum. It is a multifactorial neuromuscular and sensory disorder of the neorectum, the sphincter complex, the pelvic nerves, and the proximal colon. 3 mechanical contributors. First, loss of the reservoir. The colonic neorectum is lower capacity and stiffer, so a smaller volume triggers the urge. Second, internal anal sphincter injury. The internal sphincter supplies 55 to 75% of resting tone, and stapling or intersphincteric dissection lowers it. Third, pelvic autonomic denervation during total mesorectal excision, degrading both motility and sensation. 2 more mechanisms, and these are the newer insights. Colonic dysmotility, ligating the inferior mesenteric artery, denervates the left colon and transit accelerates. On high-resolution colonic manometry, major LARS shows more frequent cyclic short antegrade activity and fewer of the normal high-amplitude propagating contractions that should sweep from the proximal to the mid-colon. The disorder is not only in the neorectum, it is in the colon feeding it. And sensory failure, anorectal hyposensitivity, blunts the sampling reflex, and the rectoanal inhibitory reflex is frequently lost. If it has not recovered by 1 year, the dysfunction tends to persist. 2 modifiers to close the mechanism. Radiotherapy. Pelvic irradiation causes fibrosis, reduced compliance, and neuromuscular injury, with a pooled odds ratio around 2.9 for LARS. It is both a direct contributor and a marker of high-risk anatomy. And the frontier. Frequency-dominant LARS shows reduced gut microbial diversity, with fewer butyrate producers, proposed to alter colonic serotonin signaling. Bile acid malabsorption and central neuroplasticity are plausible, but I'll be explicit, still hypotheses, not established mechanisms. put mechanism against symptom and it becomes actionable. Butley reservoir loss and low compliance drive frequency and urgency. Internal sphincter injury and reflex loss drive passive incontinence and soiling. Uncoordinated colonic motility drives clustering and fragmentation. And reduced capacity with pelvic floor dyssynergia drives the obstructive incomplete evacuation picture. Later, when you treat, you are treating a mechanism, not a label. Who is at risk? People on pooled analysis, a small set of predictors reproduces with large effect. Neoadjuvant radiotherapy, odds ratio around 2.9, the most consistent factor of all. A low anastomosis, under 5 centimeters, odds ratio around 4. Total versus partial mesorectal excision, odds ratio 2. Anastomotic leak, odds ratio 2 to nearly 3. And a diverting stoma, odds ratio around 2 to 3. These are the ones you counsel on, and they cluster together in exactly the low, irradiated tumors we worry about most. Now the myths, because precision matters. On meta-analysis, female sex, age, stoma duration beyond 6 months, and hand-sewn versus stapled are not significant predictors of major LARS. Quote them cautiously. For prediction, the Polar's nomogram uses age, sex, the extent of mesorectal excision, tumor height, and radiotherapy, with discrimination above 0.75. But be honest about it. In external validation, it matched the actual LARS category in only about 39%, usually over-predicting. Use it to counsel, not to promise. You cannot manage what you do not measure. The LARS score, Emerson and Lorberg 2012, is the standard. 5 differentially weighted items: incontinence for flatus, for liquid stool, frequency, clustering, and urgency, summing to 42. The thresholds: 0 to 20, no LARS; 21 to 29, minor; 30 to 42, major. Note the weighting. Urgency and clustering carry the most points, up to 16 and 11, because they are what wreck quality of life. It is internationally validated. 2 companions with a trap. The Memorial Sloan Kettering bowel function instrument, 18 items but scored the opposite way, higher is better. And the Wexner score, 0 to 20, is incontinence specific and misses frequency, clustering, and urgency. The trap. The LARS and Wexner scores rise with worse function. The Sloan Kettering instrument falls. Cross those directions when comparing studies and you will misread the literature. Prevention starts at the table, and here the surgeon has real leverage. A colonic J pouch gives lower frequency and less antidiarrheal use than a straight coloanal anastomosis for up to a year. Level 1A evidence, 21 randomized trials with no increase in leak. A side-to-end anastomosis performs equivalently and reaches a narrow pelvis more easily. Keep the pouch 5 to 6 centimeters, build it bigger, and you trade urgency for evacuatory difficulty. One caveat stated honestly: the benefit is concentrated in the first 12 to 18 months and attenuates thereafter. 4 more intraoperative levers. Nether nerve sparing total mesorectal excision. Preserving the pelvic autonomic nerves is the single most important step for continence and urogenital function. Anastomotic height. For upper and mid tumors, a tumor-specific partial mesorectal excision keeps a rectal cuff and a higher anastomosis. Reserve ultra-low excision for where oncology demands it. The stoma. Divert only when justified and close it early. Prolonged diversion worsens function, and randomized early closure reduced urgency and soiling. And finally, leak avoidance is LARS avoidance. A leak nearly triples major LARS through a fibrotic neorectum. So a well-perfused, tension-free anastomosis is a functional decision, not only a safety one. To management. The manual consensus frames it as a stepwise ladder. Assess and exclude recurrence, then best supportive care, then specialized conservative therapy, then invasive options, reassessing at each rung and referring the refractory to a specialist clinic. We'll climb it, and importantly, I'll tell you where the evidence is strong and where a popular therapy is weak. Tier 1. Conservative and first for everyone. Diet and soluble fiber. Loperamide for the urge frequency phenotype with caution in the obstructive type. The strongest drug signal is remocitron, a 5-HT3 antagonist. In a randomized trial in men, it cut major LARS to about 8% versus 23% with only around 7% constipation. But note the limits: men only and short term. Cholestyramine for presumed bile acid malabsorption disappoints. Over 80% do not respond. Tier 2, specialized conservative, and this is the rung that matters most. Pelvic floor rehabilitation and biofeedback help the urgency phenotype, though mainly short term. But the headline is transanal irrigation. It has the strongest evidence of any LARS therapy. In a randomized trial, major LARS improved in about 62% versus 29% with conservative care. Meta-analysis shows a LARS score reduction of around 10 points, and a Bayesian network meta-analysis ranks it the single most effective intervention. Reach for it early, not as a last resort. Tier 3, neuromodulation for refractory disease. And here is a genuinely useful distinction. Sacral neuromodulation works in responders. About 91% respond to test stimulation, around 77% succeed after implant, and a long-term cohort fell from a median LARS score of 38 to 19, durable beyond 5 years, though it is less effective after radiotherapy. Contrast PTNS, percutaneous tibial nerve stimulation. In sham-controlled and pooled randomized trials, it is non-significant, and head-to-head transanal irrigation beats it. Popular, but it should not be offered as standard therapy. Tier 4, the last resort. A defunctioning or permanent stoma for intractable major LARS despite the full ladder. It eliminates urgency and incontinence, but be candid in the consent. There is no high-quality evidence that it improves quality of life. It is a symptom elimination decision made with the patient, not a functional cure. Where should we be skeptical? Prevalence estimates carry very high heterogeneity, I-squared near 90%. The LARS score, though standard, uses fixed cutoffs and may underdetect evacuatory dysfunction. Even our best therapy, transanal irrigation, has an uncertain quality of life benefit. PTNS is negative yet still offered, and sacral neuromodulation is cohort strong with its randomized trial only now arriving. And the governing manual pathway is expert consensus, not randomized trial derived. There is still no dedicated society LARS guideline. So, to the bedside. 1. Counsel every restorative resection patient and risk stratify. Radiotherapy and a low anastomosis are the red flags. 2. Protect function at the operation. Nerve-sparing dissection, a reservoir when you go low, the highest oncologically safe anastomosis, leak avoidance, and early stoma closure. 3. For established disease, climb the manual ladder. Reach for transanal irrigation early, sacral neuromodulation for the refractory, and do not default to PTNS. Measure with the LARS score and treat the mechanism in front of you. That is low anterior resection syndrome. Predict it, prevent it, measure it, and treat it by the evidence. From literature to bedside, I am Gautam Krishnamurthy. Thank you for watching.